Welcome to the Attention Deficit Disorder Expert Podcast Series by Attitude Magazine.
Hello, everyone, and welcome to Attitude Magazine's ADHD Experts broadcast. We are pleased to have Roberto Olivardia here to talk to us about eating disorders and ADHD. Before we get started, let me note a couple of housekeeping items. Those of you tuned into the live webinar may download the slides now by clicking on the Event Resources section of your webinar screen. And if you are interested in the Certificate of Attendance option, look for instructions in the email you'll receive around an hour after the live broadcast. For those of you listening in replay or podcast mode, you can visit attitudemag.com and search Podcast 358 to access the slides, the webinar replay, and the Certificate of Attendance option. And if you support the work we're doing here at Attitude to strengthen the ADHD community, we encourage you to visit attitudemag.com/subscribe and sign up for Attitude Magazine for your family or to share with a teacher or loved one who could benefit from greater understanding of ADHD. Now for today's topic, ADHD and eating disorders. Research and clinical data have demonstrated that eating disorders, primarily bulimia and binge eating, often co-occur with an ADHD diagnosis. Learning about the neurobiological, cognitive, behavioral, and emotional factors that predispose those with ADHD to develop eating disorders is the first step actually in treating them. The good news is that adults and children with ADHD can overcome the ADHD-specific obstacles that often prevent a person from moving beyond eating challenges. Dr. Olivardia is a clinical psychologist and clinical instructor of psychology at Harvard Medical School. He maintains a private psychotherapy practice in Lexington, Massachusetts, where he specializes in the treatment of ADHD, executive functioning issues, and issues that face students with learning differences. He also specializes in the treatment of body dysmorphic disorder, obsessive compulsive disorder, and in the treatment of eating disorders in boys and men. He is co-author of The Adonis Complex, a book that details the various manifestations of body image problems in men. He is a member of the International OCD Foundation, International Dyslexia Association, Multi-Service Eating Disorders Association, and American Association of Suicidology. You can ask questions of Dr. Olivardia during his presentation, and we will try to get to as many of them as we can after he is done. So with all that being said, I'll turn it over to Dr. Olivardia. Thanks so much for being here today. We really appreciate it.
Oh, thank you, Wayne. Always a pleasure to be presenting for Attitude. And for a topic that I feel very passionately about, one of my areas of specialty, as Wayne has mentioned, is I work with boys and men with eating disorders. And seeing that relationship for a lot of the comorbidity that we see for people with ADHD and eating disorders is something I feel unfortunately doesn't get recognized enough. And when the ADHD and the understanding of that relationship goes under the radar, it can really undermine treatment. So I'm here to talk about what eating disorders are, how people with ADHD can, how they are predisposed to developing eating disorders, and treatment interventions. So first, what do we mean by eating disorders? So categorically, there are different diagnostic categories for eating disorders. One is binge eating disorder, which is probably the one that you'll see most prevalent for people with ADHD. And what we mean by that are recurrent episodes of binge eating that are characterized by certain factors. Someone who's eating in a very small period of time, usually within a 2-hour period, an amount of food that is definitely larger than what most people would eat during a similar period of time and under similar circumstances. So we're not talking about somebody who maybe hasn't eaten all day, and then at the end of the day, they're eating a ton of food. Although it could be seen as a binge, but it wouldn't be sort of as much of a criteria as somebody who is eating, a very, very large amount of food on a recurrent basis. There's often a lack of control over the eating, a feeling that one can't stop eating or can't control how much or what they are eating. The episodes are also, there are a lot of factors, and typically if you have 3 or more of the following, including eating faster than you normally would, eating until uncomfortably full, and I've had patients who literally eat until they vomit, and not because they're self-inducing vomiting, which I'll talk about, but because they are just consuming so much. Eating large amount of foods when they're not hungry, not eating alone because one might feel embarrassed by how much one is eating, the feeling of disgust or self-loathing that people might have after these binge eating episodes, a lot of distress and anxiety around it. And typically to satisfy this diagnosis, the binge eating would occur on average at least once a week for a period of 3 months. Now, bulimia nervosa is basically having those binge eating episodes. However, in an attempt to compensate, and I use that word in quote, compensate for the binge eating, that in an effort to try to prevent weight gain, individuals will do things like self-induced vomiting. They'll make themselves vomit. They'll use laxatives, diuretics, or other medications, have fasting episodes, or excessive exercise for the sole purpose of undoing the binge. Now, and I put that word in quotes because what I always tell my patients, for the majority of people actually who struggle with bulimia nervosa, are not underweight. They actually could be seen in sort of a typical weight range, or actually might be slightly overweight. And what happens is that the body, we are only meant to vomit when we have a toxin in our body. So evolutionarily, vomiting is to try to get rid of a poison or something that we should not have in our body. And it gives us sort of like a little euphoric rush to then give us enough fuel and energy to make up for those calories that we just lost, and to find other food sources or something that will soothe us. What happens is that for individuals who engage in bulimia, that if any of us were to self-induce vomiting and have that be a regular thing, then what happens is the body picks up on that quickly and says, oh, this isn't going to be healthy. Let's absorb the fat of when somebody eats as quickly as possible. So a lot of times when people think that they're vomiting the calories from fat, that's actually the last thing to go. When people, especially the more often that people will self-induce vomiting, they're losing water, they're losing calcium, they're losing protein, they're losing actually all the nutrients. And the fat is the last thing to go, because the more that somebody engages in that behavior, the quicker the body will try to hold on to that body fat, because it anticipates that it's going to lose it. And at the end of the day, if we were in a famine situation, we would survive longer on a Big Mac from McDonald's than we would a bowl of salad, because there's fat in that Big Mac. Now, obviously, that wouldn't be a healthy way of eating on a daily basis, but when push comes to shove, we need that fat. So when we use the word compensatory, it's more of a psychological compensation rather than an actual physical or medical one, to the degree at least that people see it to be. So the binge eating and these compensatory behaviors can occur on average at least once a week for 3 months. And often there's a lot of body image distortions, or a lot of negative body image that people hold their sense of self very much attached to. Now, anorexia, the binge eating and bulimia are both impulsive eating disorders. A more compulsive one is anorexia nervosa, which overall is you aren't going to see as commonly for people with ADHD. However, it's important to mention, because I have worked with boys and men, I specialize with boys and men who have ADHD and anorexia. So it's not impossible either. And by anorexia, we're talking about a restriction of calories, a restriction of energy that is, for someone of that body weight, where they're really going below sort of the developmental norms. There's often an intense fear of gaining weight or becoming fat. And there's often body image distortions, and the restricting people who can have anorexia can also binge eat and purge as well, but the primary modality is that they're restricting. Now, a lot of times I'll work with boys who the parents will say, well, he's not talking about sort of a fear of gaining weight, and I don't see the negative body image. Could it be an eating disorder? Well, there's a couple other categories. One is called avoidant restrictive food intake disorder, or ARFID. And that is basically a disturbance in eating where somebody isn't meeting their energy needs or their nutritional intake appropriately. It can result in a loss of weight or not gaining the expected weight gain that you would expect them to. There's often malnutrition in terms of nutritional deficiencies. Sometimes they have to depend on either intranasal feeding or nutritional supplements. And there's often a lot of interference in psychosocial functioning. Now, what you see absent in this diagnosis is negative body image. And so just because somebody doesn't, if that's absent, they don't need to have a fear of fatness or a fear of gaining weight, but you see these other characteristics of their restriction of certain calories that could also satisfy the criteria of ARFID. So that's important to know, because sometimes I get asked by parents whether insurance, is there a diagnosis if you don't see that negative body image? And yes, in this case there is. There's also something called other specified feeding or eating disorders. This used to be called eating disorders not otherwise specified. And it could include a number of different things. These are common ones. One is atypical anorexia, where somebody meets basically all the criteria for anorexia, but they might not have significant weight loss. They might not be emaciated. Their weight actually could be within normal limits, but they could still be restricting tremendously and have actually a lot of the health impact of somebody who might be underweight in terms of the nutritional deficiencies. Bulimia nervosa, but they might not be meeting the criteria of this many times per week of binging or purging. And these things, all of these disorders too, are not necessarily minor, in the sense that I've worked with patients who might binge and purge once a week, who develop major medical problems, perhaps more than a same age peer who might be binging and purging 3 times a week. So I don't want people to think that these disorders are necessarily less impactful to the health, because at the end of the day, these are things that really are creating major harmful impact to the body. Binge eating disorder, similarly, with lower frequency or duration, could still fall under this category. Purging disorder, I've worked with many individuals who do not binge eat, but they just purge. So with individuals with bulimia, the purging is typically following a binge, but I've worked with people who eat a normal sized meal and they'll purge. Or they might not even purge right after a meal. It's almost like the purging, and I'll talk a little bit more about why that might be, particularly for people with ADHD. Night eating syndrome, which refers to individuals who, and is typically coupled with sleep disturbances, might get up in the middle of the night and they start eating. And they're not hungry. It's not that they're necessarily needing those calories, and it's only happening in the nighttime. Something called chewing and spitting disorder, which includes individuals who will, let's say, have a cupcake, they'll chew it, and their saliva will sort of get the taste of the food, but they never actually swallow the food. So they're not purging the food, because the purging means that they've swallowed it, they've ingested it, and then they're regurgitating it. With chewing and spitting, they're merely just chewing the food, spitting it into the barrel, but getting the taste of it. These are all eating disorders. There's another disorder that's not in the DSM, but is one that's also important to note, which is called orthorexia. And this can look like anorexia nervosa. And it's very important to understand the difference. With orthorexia, we often see this as sort of an obsessive compulsive spectrum. These are individuals who perhaps could present in my office as being emaciated, who are not eating enough, but they're like, no, I don't have a fear of being fat from an aesthetic reason or body image purpose. I'm just obsessed with eating clean and eating healthy, eating organic. And it can get to a place where that gets very obsessive, where I'm only gonna eat raw foods. I'm not gonna eat any foods that are sprayed with or farmed with certain preservatives. I have to eat every 2 hours because that's what's optimal, because I've done research that shows that people who live to be 100 eat like this. And so there's this real rigid adherence to eating in a certain way that's really I mean, often these people carry a high value around health, and then this disorder often moves them away from that value, which obviously can be really frustrating to them. They're constantly thinking about food. They can spend hours in food preparation and storage, shopping, reading about food. They value healthy eating to the deferment of other life activities. But again, they're not motivated necessarily by thinness from an aesthetic purpose. They might be motivated towards leanness from a health perspective, that they don't want to be obese from a health perspective, but it gets really out of control to the point where patients I've worked with orthorexia are eating very close to nothing because you can find something not clean, not healthy, inorganic about virtually everything that we eat, including water. I mean, I worked with someone who was really afraid of drinking water because even spring water found out that there was mined in the ground that could have this preservative and was restricting, water, which obviously you can't do that. I mean, and then would have to, drink. So eating disorders affect about 30 million people in the US. And it's important to note 20 million are women and about 10 million are men. And I can give a whole talk about men and eating disorders. As Wayne mentioned, I co-authored a book 21 years ago, called The Adonis Complex. Men make up about, even with this statistic, it might even underestimate. Current statistics show that about 1 in 4 people who have an eating disorder are male. However, men, when they look at treatment samples, that 1 in 10 to 1 to 16 eating disorder patients are male. That means there are a lot more men who are struggling with eating disorders who do not seek treatment. And many eating disorder residential facilities don't accept men. So there are more men out there than people think. What's very important about what I'm trying to communicate in the importance of getting treatment is about 15 to 20% of people who struggle with various eating disorders will die from the illness, and it has a high mortality rate. And the mortality rate isn't just for medical complications. There's actually a very high rate of suicide in individuals, particularly with anorexia nervosa, as well as bulimia nervosa, but just a lot of medical complications that can really affect mortality. So very important thing to keep in mind. I've worked with 21-year-old athletic men who have had heart attacks and cardiovascular events due to binging and purging behavior. There are various causes that really factor into eating disorders, genetically, biologically, certainly socioculturally. Trauma can play a role in it, and comorbid disorders, of which we'll be talking about one of them, ADHD. Only 10 to 15% of women with eating disorders seek treatment, only 10 to 15%. So as a whole, this is a psychiatric and medical illness of which you're going to have the minority of people that are actually seeking treatment. And when we look at men, it's even a smaller percentage. However, I want people to walk away with the notion that recovery is possible. It clearly takes a lot of work, but it's absolutely possible to recover. And I worked with a man many years ago. He was 72 years old. He had a combination of sort of anorexia and bulimia. He had it since he was a young child, and he sought treatment at 72, and he recovered. And he said he, is no longer with us from natural causes, but he said that the years, that he had free of that were probably the best years of his life. So it's never too late. Eating disorders carry a lot of medical consequences. Everything, sort of the quote, minor ones could be things like dental problems from purging. When you purge, you're putting yourself at risk for losing the enamel on your teeth, which can result in your teeth later falling out. You can run the risk of esophagitis or esophageal cancer because you're burning sort of the lining of your esophagus that actually protects it from certain bacteria. Hair loss, dysregulating metabolism, sleep problems, temperature dysregulation, and certainly all ADHD symptoms for those people who have ADHD get exacerbated by these medical consequences. On more serious levels, you have cardiovascular problems. When we purge, it disrupts our electrolytes, which are chemicals basically that regulate our heart and regulate our heart rate. So when someone is purging, and again, it's not necessarily like a certain number of times that will trigger and could potentially trigger an arrhythmia or a heart attack. It's gambling, basically. Gastrointestinal problems, neurological problems, endocrine problems, hormonal issues, kidney problems. It's associated with very adverse medical consequences, and not just ones that will appear at the time. Particularly if you take something like bone density for individuals who struggle with anorexia, that if you're not getting the proper calcium and protein in your body at very formative years, you're really setting yourself up to have very poor bone density. So I've worked with men in their 40s and 50s who might have the bone density of someone in their 80s. So if they fall, they could literally be disabled in the ways that somebody when they're 80 or 90 when they fall could be. So how does ADHD factor into this? So I'm just going to shift a little bit to what we know about ADHD and eating. Studies will show that people with ADHD can be quite impulsive with their eating habits. One study in looking at a lab of 10 to 14-year-olds where they looked at what food they liked, how hungry they were, and divided the kids in the ADHD group, the non-ADHD group. They found that the kids with ADHD in a simulated kitchen ate a lot more food, and this was not influenced by their mood state, level of hunger, or even their liking of food. And that's significant. So even for foods that they didn't like, they tended to eat more of simply because it was there. People with ADHD tend to have more disruptive eating habits. They tend to eat less of a nutritional diet and are drawn towards high sugar intake. And studies looking at individuals with binge eating disorder and in obesity populations finds a very high prevalence of ADHD. This is a study of 215 patients who presented for gastric bypass surgery, found that 27% had ADD. And when they actually looked at people whose body mass index was over 40, which is morbidly obese, that 43% of that sample had ADHD. And not only in terms of predisposing factors, but even post-gastric bypass, the group with ADHD tended to lose less weight, even after getting a major surgical procedure. So what's important about that is when the ADHD is not recognized, if it's not treated, then it's going to undermine anything that somebody is trying to do. A lot of times people wonder, well, is the hyperactive type of an ADHD maybe less likely to develop weight issues or eating problems? Do they eat less because they're always on the go? Studies actually find that's not the case. This was a study looking at almost 100 ADHD male patients who were of the hyperactive subtype and found that they were significantly more overweight than a reference population. And similarly, when they looked at people who were over the 90th percentile in body mass index, that ADHD was significantly more common. And when they look specifically at eating disorders, bulimia nervosa and binge eating are the two that are most commonly studied with ADHD. You'll see, as Biederman found, that girls with ADHD are 3.5 times more likely to have an eating disorder. The University of Virginia, as well as the University of California, found that bulimia is more common in ADHD adolescent girls than girls without ADHD. Craig Sermon found in a sample 11% of women with ADHD satisfied the criteria for bulimia, where only 1% of a reference non-ADHD group had bulimia. Seeds found that 21 in a sample of people who were being treated for bulimia found almost a quarter of, well, more than a fifth of them, 21% had ADHD. Now, obviously, these are studies that are particularly looking with girls and with women. There are very few studies that even look at men. About 1% of eating disorder research focuses on boys and men, and none that I'm aware of have specifically looked at bulimia with males. But I can tell you in my practice, many of the men that I've treated with bulimia and binge eating disorder have comorbid ADHD. Similarly, again, you'll see studies where 31% of over 1,100 eating disorder patients satisfy the ADHD screening cutoff. and then a meta-analysis, which is looking at a collection of different studies. ADHD had a threefold risk of eating disorders, and the eating disorder was more severe when ADHD was present. So ADHD also presents an additive fuel, in a sense, to the presentation and the severity of eating disorders. So again, and there are no current studies that have actually focused on anorexia and ADHD. And again, it's not as common. You'll often see more obsessive compulsive disorder in people with anorexia, but that's not to say that it doesn't happen. So why is it that people with ADHD are predisposed to these problems? So we know that the ADHD brain has a reward deficit, that we have all these neurochemicals in our brain. One of them is dopamine, and that is implicated in reward. And food can be highly rewarding. And keeping in mind that the food that people binge on is typically high sugar, high simple carbohydrates like potato chips and white bread and cake. It's nobody is that I'm aware of that I've ever worked with binges on kale and and carrots. That it's usually going to be things that really stimulate a reward in the brain. And so for people with ADHD who are more vulnerable and always seeking that kind of reward in their environment, food is this very accessible level of reward. Another neurotransmitter, GABA, which basically when we have appropriate levels of GABA, we're appropriately inhibited. So for lots of people that might want that second slice of cake or that third slice of cake, but say, I probably shouldn't because I'll probably feel gross afterwards, or I might be too full, so I'm not going to have it. That's appropriate levels of GABA. And good executive functioning. For the person with ADHD, we know ADHD brains have lower levels of GABA. So you have an understimulated, uninhibited brain, which can lend itself to getting highly rewarded in the same way that we see for people who are addicted to drugs. The fact is, not everybody will have the same response, let's say, to alcohol or to cannabis as someone else. That's why no one should judge when people are like, oh, how do these people get addicted? Well, it's because their brain is getting a certain reward from it. Now, that's not only true for binging. Purging can also stimulate levels of dopamine and have this euphoric and almost addictive. I mean, it is an addictive stimulation. And that's why there are some patients I've worked with who the binge eating is really the desired behavior and they purge to try to compensate for the binge. But I also work with people who binge so that they can purge, that the purging is the thing that they're really seeking, sort of the response that they have in the brain. And my ADHD patients who engage in purging behaviors will say they feel so focused and so grounded and so clear after that. Very dangerous, very, very dangerous behavior. However, we want to hear from our patients, what is the appeal? Like, what is drawing them to it so we can help understand that. Now, even with restriction, I have worked with some people with ADHD and anorexia, that restricted behavior can also build up a reward sensitivity. And this isn't just with anorexia, even for individuals who binge eat, and even for people that might not have sort of the criteria of eating disorders. I've heard this from ADHD patients, where they will purposely restrict. And it's not for fear of fatness or body image. They'll restrict so that when they eat, it'll feel that much more like rewarding to them. So they're almost setting up like this deficit so that when they finally get it, it's going to feel that much stronger. It's also not uncommon for people with ADHD when they engage in some high dopamine related activity. It could be sex, it could be having fun, it could be anything that sort of creates that sort of level of dopamine, that there's sometimes this sense of trying to keep that dopamine flow going. And binge eating, I've heard from many of my ADHD patients, can be a way of doing that. So it's not always the triggers that we think it could be. I have a patient, that I was working with for a long time. He's in recovery now, but said that it wasn't that he was angry or stressed. He goes, in fact, it would always be after I was doing something fun. And it was like to prevent the downfall of like, oh, now the fun is going down. Like food, he said, would be that thing that would sort of like bring it, back up. So like he said, happiness was his trigger, which is interesting. And we know that there are genetic qualities to that. The ADHD brain has certain receptors that overlap with obesity and with binge eating. So it's not at all surprising that this would be a comorbidity that we would see. Alan Zemetkin has done studies that look at the brain and find the ADHD brain is slower to absorb glucose. So even, studies will show, for example, that individuals, when they're sipping a sugary drink, that the person with ADHD can take in a lot more than the non-ADHD person before they feel like, whoa, that's too much. And I can speak from my personal experience as someone with ADHD that I remember when the culottes came out, the strawberry culottes from Dunkin' Donuts in the 90s. I was in graduate school, and they're like, these big slushies. And I mean, it's sugar. It's basically sugar, red dye, and ice. And I had one, and I thought, oh my gosh, this is like the best feeling. I want to feel this way all the time. And I slurped the thing down, went to class, came back, coming back home, bought another one and went home. And I remember my brother was at my house and my wife, and I first said, oh my gosh, you have to try this. This is so good. And they were both like, why do you look like really excited about this drink? And they sipped it and they thought, oh my gosh, this is so disgusting. Like, this is so sickeningly sweet. And I'm like, really? I'm like, well, I know it's sweet. That's why I like it. But it's clear that the way my brain can respond to that is just very different, which is why but that's helpful information, because I drink my coffee black for a reason. Because when I started drinking coffee in my early 30s, it was basically, having sugar and pouring a little coffee on it. Now it's very different. Serotonin, which is another neurotransmitter that induces calmness and well-being, is boosted when you have high carbohydrate intake. Also, as we know, ADHD is heritable, as are eating disorders. There are genetic predispositions there. With people with ADHD, dysregulated eating can also be very much tied to poor executive functions with the ADHD. We know that people with eating disorders lack what we call an interoceptive awareness, which means their ability to cue into and tune into what's happening inside their bodies. Am I hungry? Am I full? Am I satisfied? For people with anorexia, they might feel that they're full when they don't have food in them. We know people with ADHD also have a poor interoceptive awareness. So I decide that I'm not hungry when the food is gone. It's sort of the motto for many people with ADHD, as opposed to, no, there could be more of that food that I like there, but I'm satisfied, I'm done. All the executive functioning issues around preparing and eating healthy, making decisions. A lot of patients do what they call, and I call procrastinating, that when they're procrastinating, food becomes this sort of just reward that just kind of grounds them and gives them something to do when they're faced with a dreaded task. Food sometimes with ADHD patients could be a way of trying to gain executive fuel. Like if you don't feel like you have enough juice, basically, in your frontal lobe, that it could start out, well, let me eat something, and then it can spiral into binge eating episodes for a lot of individuals. In the case of restriction, I've also seen that sometimes where patients of mine with ADHD might have started down the road to more that ARFID, that avoidant restrictive intake disorder, that it wasn't that what looked like anorexia, it wasn't caused by body image, but they said, you know what, there's so much work in preparing food and what's the right thing to eat. It's just easier not to eat. Like, it's just easier to be all or nothing. Now, many people with ADHD would be like, I don't even understand that, like not eating, but it makes sense when you understand the mechanism of it. And so I've worked with individuals who fall under that ARFID category. And it's not that they don't like to eat. It's not, they're just almost like, this is just one less thing I have to think about in this internal executive chaos. Also, ADHD and OCD are comorbid. And we know that obsessive compulsive disorder can also be a factor in these eating disorders. Impulsivity, particularly with the impulsive eating disorders, very inherent in people with ADHD. People with ADHD are not very good at self-regulation, even underestimating the amount of calories they eat. When I work with my eating disorder ADHD patients and ask them, to even keep a log of what they're eating, and oftentimes I have them just take pictures because they might lose sort of what they're writing down, or they don't always have something to write down. I said, just take a picture every time you eat something. And before we look at the pictures together, I asked them to sort of recall, and they're like, yeah, I didn't really binge that much. And then they look through these pictures and they're like, oh, I forgot about that. Oh, and I forgot about that. So part of that is also inherent in ADHD. If your working memory, if your ability to attend to those things is off, then even recognizing the problem, because I've worked with many people with ADHD, they don't come to see me because they have a binge eating disorder. They come because they have ADHD and some other issues. And then because in my intake, I always ask about eating and sleeping habits, it gets revealed that, oh no, that's an eating problem. Like that's a binge eating problem. Poor sleep habits can also dysregulate metabolism. It can basically exacerbates all ADHD symptoms. If people skip meals, that makes you hungrier, and it makes you hungrier for sugar. It makes you hungrier for fat, for simple carbs. A lot of people with ADHD eat while doing other things, which then can really dysregulate their mindfulness around that. Restrictions sometimes can also be a compensation for impulsivity. I've had patients with ADHD who say when they starve themselves, they are just, it's almost their way of just not having as much hyperactive energy because they feel all over the place. And it's almost this defense to kind of calm themselves. Obviously not healthy one. Emotions. We all can relate to people who stress eat. But honestly, the number one thing I hear is that could be a predisposing factor to binge eating is boredom, that food is stimulating. It can also be for medicating depression and anxiety. Food can be a reward. It could be a relief from those racing thoughts and distractions. Like if you're just focused on food rather than focusing on the 10 things that you might have to do, there's something that could be very reinforcing about that. All the sensory aspects, we know ADHD people are sensory seekers, and food is as sensory as it gets. And the taste and the smell and the visual and, the touch, all of those things. And patients of mine will say it's not only just the food that can be very grounding, but even thinking about binge eating can be very grounded. Even thinking about food is very, already almost stimulates that reward. Now, for a lot of people who struggle with eating disorders, there could be issues around self-esteem, where people often don't feel very good about themselves and their self-worth. And eating disorders and body image issues can be manifestations of those self-esteem problems, which is part of the treatment. And we know that for a lot of people with ADHD often struggle with self-esteem due to failures that they might have had in their life because of their ADHD symptoms. All these unrealized intentions, particularly if people are undiagnosed. I've worked with many adult men who their ADHD gets diagnosed as we're working together, who might come to see me because they have a binge eating disorder, and it was never put on the radar that they also have ADHD. And so when they're talking about their self-esteem problems, getting fired from these different jobs, these relationships, and when I hear why those things were problems, it is all related to untreated, unmanaged ADHD. Negative body image can also result as a means of coping with weight loss, weight gain. Food can become a very easy way to cope for a lot of people. The act of purging feels like the sense of gaining control. And if a lot of people with ADHD don't always feel like they have control over their lives. And so what I put in my mouth or what I release from my body, I have control over. I've had patients say, I can eat today because I've been good. And so food is sort of the sense of I was good today. I checked off everything I was supposed to do on my to-do list. But eating disorders can also be a form of self-punishment and self-loathing. So purging isn't always about trying to undo calories. Sometimes it's equivalent to a self-harm behavior. But instead of cutting, it's purging. Nobody, I had a patient who said, like, nobody looks good in the mirror after they purge. Like, it's almost this sense of, look how bad I am that I'm doing this disgusting behavior, this secret. There's something that definitely is very equivalent to what you would hear for people who struggle with addiction, this sense of secrecy. The focus on weight can be very concrete for their self-esteem. And I've heard many times from people, if I can control my weight, then I feel in control of my life. And if controlling my weight is the one thing I can succeed at, then that's what I'm going to do. So again, all of these things really relate to ADHD. And really these negative body image and dealing with all this could really be an extension of self-esteem problems. So in terms of treatment, it's important to note only 10% of people with eating disorders receive treatment, which is very, very low. So we need to do better in terms of more outreach and encouraging people to talk about these issues, because there's so much shame for people who struggle with these problems. And the key is we need to always, if someone has ADHD and an eating disorder, we want to address the two together. We can't deny the ADHD. And it's very important if you or a loved one has ADHD and an eating disorder, if the clinician is thinking that the ADHD is not really as relevant because you're not in school anymore, or, oh, this isn't an issue of focus, they need to be educated, because unfortunately, I've talked to clinicians and done consultations where psychologists who don't understand ADHD think it's just an issue that affects someone academically, and don't understand how that absolutely could impact and even be sometimes the real driver of the eating disorder. We always want to understand how ADHD impacts the eating disorder and is impacted by the eating disorder. We want to destigmatize ADHD, especially for girls and women. There are a lot of girls and women who, as we know, I mean, although Attitude and CHAD and all these great ADHD organizations are doing their job of saying, hey, we need to recognize this in girls and women, and still in popular culture, a lot of women still are either massively underdiagnosed. And we need to destigmatize eating disorders in general, but especially for boys and men. I for a lot of the adult men that I work with, I am the only person that they have even revealed that they have an eating disorder. Their wives might not even know, because there's so much shame. So the bottom line is we need to treat the ADHD in order to help treat the eating disorder. And so treatment for an eating disorder is multimodal. It really is, often involves a team of people, a psychologist, often a psychiatrist, a nutritionist, sometimes a family or couples therapist. But where the ADHD is in executive functioning skills training, cognitive behavioral therapy, where you're addressing negative thought patterns like all or nothing thinking. If I eat a cupcake, I might as well eat 10. Well, no, that's faulty thinking. You can have one cupcake. It doesn't mean you've broken a rule enough that you have to have 10. But with cognitive behavioral therapy, there is an assumption of good executive functioning. And so we have to adapt that to our ADHD patients. I think of it as think of myself as like a creative coach sometimes. So the example I gave earlier of taking a picture of food, rather than food logs, where every time you eat something, write it in a food log. How did you feel? Well, that requires someone to have that piece of paper, to remember where it is, to bring it to the session. And unfortunately, I've worked with patients who, in past treatment experiences, were told that they weren't trying hard enough, that they were being treatment resistant, that maybe they didn't really want to get better because they were like, oh, I forgot the food log, or I didn't do it. And we know that couldn't be farther from the truth. So we have to work at understanding how the ADHD works to make sure that treatment is working. DBT, which focuses on mindfulness, emotion regulation skills, interpersonal effectiveness skills, tolerating distress, very helpful in patients with eating disorders. I think it, frankly, is helpful for anybody, but could be very helpful for people with ADHD and eating disorders. ACT, or acceptance and commitment therapy, looks at value systems, basically, that people hold. So, for example, if somebody, because eating disorders really aren't about, I want to look good, in that kind of way. It's we're always looking at what is the value behind it. And what my patients will say is, well, I want to look good so that people will like me. I want to look good so I can have relationships. Well, wanting to be liked and have relationships is a value. We're social creatures. No one is faulting that. But let's extract the value from now the behavior and ask ourselves, is that behavior really carrying out that value? No, I've worked with models who have eating disorders, who objectively anyone would look at and say, that is a very attractive person, and they still struggle with self-worth. So clearly, it's like the hole in the soul that a lot of times we're with eating disorders is people who are funneling it into that. But even for people where it's not body image related, that it could be sensory issues. It could be, a lot of other things, like in the case of orthorexia, the value is health, but then part of the work is understanding that behavior is moving away from the value, not towards it. And then, of course, addressing any self-esteem issues, working with a nutritionist is essential for people with eating disorders, just even knowing how to eat. Like, what are the things we're supposed to eat? There's so much confusing and conflicting and overwhelming information out there that particularly for people with ADHD have a very hard time sifting through, because you can read, are eggs good or eggs bad? Is this good? Is that bad? And working with a nutritionist who can help with that. Group therapy can be helpful, parental coaching, and then medication. And I want to emphasize this because and we've seen this in the eating disorder community, which I'm a part of in terms of, and feel, have wonderful colleagues in that community. However, there are some individuals in that community who would think that a stimulant is contraindicated treatment for someone with an eating disorder. And I emphasize, with someone with ADHD and an eating disorder, studies show that the stimulant treatment actually helps regulate their eating. It regulates their impulsivity. And in fact, and no surprise to me, the first FDA-approved medication for binge eating disorder is Vyvanse, which is an ADHD medication. Not a coincidence. And so it's very important that if you're working with someone who might not understand the ADHD and say, stimulants suppress the appetite, that could actually fuel the eating disorder, or they worry whether people are faking an ADHD diagnosis to get their hands on stimulants to quell their appetite if they are looking for weight reduction. So it's very important to obviously get the proper assessment, of ADHD and understand that the stimulants can help. There are no approved medications for anorexia, partly because when a body is in a starved state, it's very hard for anything to metabolize. That's not to say that medications can't be prescribed, but they're not sort of targeted and proven with studies will show, versus like a stimulant for ADHD or SSRIs or FDA approved for bulimia, nervosa, that can help with regulating mood and obsessionality. So research studies show that stimulants can really help with that, and that's important, to communicate. So I am going to end there. We have about 15 minutes for questions.
Wow, that was excellent. Really. And it evoked a lot of great questions, so many great questions. I don't know where to begin. I'll start with one with this mom is worried about her 25-year-old son who has a sensory-based eating disorder. He'll stop certain textures, stop him from eating. Sights, smells, and even thoughts affect his eating. For example, if someone mentions dirty dishes or garbage during a meal, he gets grossed out and leaves. The problem this mother is facing, he also has ADHD, is that his repertoire of foods that he will actually eat is growing smaller and smaller. And this woman is a pediatric occupational therapist, and she's looking for some help. So I don't know about next steps here.
Yeah, so that's not uncommon in what I've seen sometimes with individuals. So first is that there could be other diagnoses at play here. So ADHD, one, I'm not referencing this particular person, but for other patients I've seen where autism spectrum, obsessive compulsive disorder. And again, all of these things we know ADHD rarely travels alone. And so all of like when she mentioned the garbage thing, I worked with a patient where it's very similar, that he didn't have a problem eating, but the conversation in the family, he got triggered by certain words that would create obsessions in his head, that if it was anything that was either gross or dirty, like garbage, dirt, certain words, he would respond by getting very angry at the family member and saying, now I can't eat because now I'm thinking of that. And to him, it's almost like an OCD, we call it a thought action fusion. Like it's almost like now the meal is that, like it's dirt that I'm eating, it's garbage that I'm eating, it's all of those things. So for him, the treatment was an obsessive as an OCD model where we had to do exposure therapy, exposure and response prevention, where in the office we would eat meals, and not only would, in conversation, I would say those trigger words, but we might even see a YouTube video of, a landfill or something like that. Now, I'm not saying that's a one size fits all. Again, it's very important to properly assess all of the things at play. For people on the spectrum, who can have a lot of sensory defensiveness, as well as people with ADHD, you want to assess, okay, how much, in terms of exposure to start to expose that person. And this is where a nutritionist can also be very helpful, in addition to maybe an occupational therapist, is, I remember working with someone where all they ate were chicken nuggets and macaroni and cheese. Those are the only things that this person ate. And so we tried, and it not only was chicken nuggets, but it had to be a certain fast food brand of chicken nuggets. And so then we would start by, okay, let's eat the nuggets, but let's peel off the skin just to even create a differentness, because there was this wettedness, this wetted sense of sameness and everything. And that's part of what it could be. It's like a lot of individuals who have, they often refer to it as selective eating disorder, like really picky eating. It's around this sense of like, there's certainty in what I'm eating. There's certainty that I'll eat these nuggets and I know how I'm going to feel afterwards, and there's no surprises. So really trying to encourage anything that's different. So if it starts with, you'll eat the nuggets, but let's peel off the skin and eat it. Now we're creating some flexibility. And then maybe we'll get chicken nuggets, but instead of McDonald's, Burger King chicken nuggets. And then, you sort of work, but that's what I would recommend the person meet with a nutritionist who has experience working, with this, because they have a good sense too of, well, one, you want to make sure that that child is getting the proper nutritional input. And so that's where supplementation might be necessary, smoothies or things like that, where, frankly, it'll be our secret, but parents will sneak in nutrients in the smoothies to try to, make sure that, because you're also dealing, particularly with children and adolescents, these are formative years in terms of, setting their bodies up hormonally, setting their bodies up physically, that you want to make sure they're getting their nutritional needs. And it's typically associated also with personality traits or risk aversion. Like a lot of times, how we eat is very indicative sometimes of other personality traits. Like there are some people who are like, I will eat virtually anything. And I'm a very adventurous, and that is in line with sort of other aspects of my personality, versus individuals that are like, oh, no, are often individuals that have a hard time, not only in food related situations, but in other situations. And sometimes the work is also in engaging in those other situations. How do you, because the food thing can get very embattled. There can be a very hostile dynamic between a parent and a child. And I feel for these parents, because it's really, really hard when you can't force feed, a child. And at the same time, you want them to get the nutrients that they need. So I would recommend working with a nutritionist and an OT, because even though, just as I know, I'm a psychologist, but to my kids, I'm their dad first. So I can say something that a teenage patient might hear because I'm their therapist, versus, as a parent sometimes might be taken in a little bit differently. So working with an OT, nutritionist, a therapist, making sure that every other part, because sometimes it's anxiety. I've worked with people who their eating disorder is really developed by a fear of choking. I worked with someone who they misdiagnosed him with anorexia, and he said, he goes, I know I'm thin. I don't want to be thin. I actually have a negative body image for being too skinny, because my issue with food is that I'm so fearful of choking. And it was this obsession and this anxiety around choking. So you want to make sure you're assessing all of the things at play.
Well, it sounds what's coming clear is, and that was one of the questions I was going to ask. Asking a clinician to be able to evaluate and treat all of this sounds like too much of a challenge. That basically it's a team approach, right?
It's definitely a team approach. Eating disorders it's very, because you are dealing with a medical like a very medical issue. So you want to make sure that you're having, so like I'm not a nutritionist, so I can make general recommendations, but with an eating disorder patient, there's always a nutritionist on the team because I'm not equipped to really, and I don't have the education of handling that, and having sometimes an OT on board as well, certainly a therapist. Sometimes it's, parents need that support and coaching. It's very hard to
Right.
What do you do when you feed your kid? Do you just leave it there? Do you make them sit there until they eat it? And that they need that support. So absolutely multimodal team.
Is stress eating, where one eats to soothe or smother feelings, considered an eating disorder?
It can be, certainly. I mean, it's certainly, I would, when it's a common thing, I would refer to as like a disorder, certainly disordered eating, because your relationship with food is not one around nourishment. It's not one around, enjoyment. It's really to sort of deal and cope with feelings, which is a little bit different. Now, for a lot of my patients, it starts with stress eating. They eat and then they feel either better or they feel so numb because they've overeaten. And then it becomes like, oh, that helped. And then it just becomes, it's again, similar to how you might hear with drug abuse. Like a lot of people, who maybe smoke cannabis for the first time might just do it because all their friends are doing it. And then for the person with ADHD, they get this high reward and they think, oh, wow, this is like grounding me. I feel so like I can fall asleep. Let me keep doing this. So it can absolutely lend itself to that. Have all of us had periods of time when we might be stressed and we're like, oh my gosh, I just want to have Ben and Jerry's? Absolutely. Like having it, here and there is not an eating disorder. But if it's your primary way of coping, then there's a problem because life can be stressful. I mean, we're going to have stress and we can't have food be the thing that's going to do that, because the other thing is that right after you eat that ice cream, that problem is still there. So it might numb you temporarily, but it hasn't solved anything. Whatever that thing is that you're stressed out about is waiting for you right after.
One person has asked, are eating disorders sometimes misdiagnosed as ADHD due to the effects of malnutrition on the brain that can lead to sort of lack of concentration and focus? And if so, should someone be diagnosed with ADHD once they are in recovery from an eating disorder?
So eating disorders, particularly with malnourishment, I mean, with anorexia, you definitely see, people with anorexia, and I've worked with some, pretty serious cases where their cognition, your brain is just not working. It's just you have no sense of concentration or attention span. So it could happen, absolutely, that, that's why when I do an assessment or even on, again, an intake for any patient I work with, regardless of ADHD, eating disorder, depression, I ask, what are your eating habits like? Because if somebody says to me, I can't concentrate, I can't think straight, and then they tell me, and I ask them, oh, what are your eating habits? And sometimes I'll get responses like, oh, I eat, one meal a day. And they might be a 200-pound, 5'10" adult male. And I'm thinking, well, that one, and then I ask them, what is that meal? And it's far below the calories they should be eating. Then, I'm like, okay, and that has to be filed. So then I have to put that into consideration. Now, is that a result of ADHD, or are all of their attention and concentration issues related to that? And that's where you get family history and you get, history of when they were eating in a more regulated way. So absolutely, to that point of unhealthy eating, absolutely can lend itself to inattention, to concentration issues, to poor executive function, without a doubt. So we want to make sure that is being sort of ruled out, but keeping in mind that people with ADHD have, as this presentation, have dysregulated eating. So even when you do meet with someone whose eating is out of whack, that doesn't mean, oh, well, that's all of the cause of what's causing this, and they don't have ADHD, which sometimes I've seen that, particularly with like sleep issues as well, like people who might have poor sleep, and doctors say, well, I don't think you have ADHD, you just have this real dysregulated sleep. And at the same time, we know that people with ADHD have are more prone to sleep problems and sleep disorders. So you definitely want to tease that out.
Mm-hmm. All right, I guess I have time for one more. I'm sorry, there are just so many good ones. Does an eating disorder affect quality of sleep? We know ADHD does.
Absolutely. So this is the thing and we have to think of ourselves in as scientific terms as possible in terms of evolution. So on an evolutionary basis, we need to do three things to keep ourselves alive. We need to eat, we need to drink water, and we need to sleep. If we don't do those three things, our bodies will degrade and will die. So what happens is that when we have and this is true for anyone with ADHD. So when we are sleep deprived, for example, so people with ADHD often go to bed too late, don't get enough sleep. When we're sleep deprived, we have to think of our brain as its own entity in a way. So our brain says, wow, we're only sleeping 3 hours. What can be so important to have me not sleep? Our brain isn't thinking, ooh, Netflix, that's an important thing for our evolution. No, our brain is thinking our food or our water supply must be threatened in some way. So if that's the case, again, this is what's amazing, Wayne, and this is what I have such an appreciation for our bodies is our bodies will then do, when we are sleep deprived, it will lower our metabolism, and it will increase hormones in our body that literally crave fat and sugar. And that is a way of survival, because when we were back in the day, cavemen and cavewomen, like if we could go days without real adequate food supply, our body has to hold on to whatever, fat and everything, and nourishment as much as possible. So, but what's important for people with ADHD who have dysregulated sleep to know is you are altering your metabolism by that sleep deprivation, which is setting you up to make more impulsive decisions. And literally, it's almost like a roadmap towards eating the kinds of foods that typically we see as less healthy. Now, the opposite is also true. People who have eating disorders, because I also treat boys and men with eating disorders that don't have ADHD, but when you have eating disorders, that can also disrupt your sleep cycle. Because let's say you binged on 8,000 calories at a certain time of day, your body might either, I've worked with people who literally pass out from binge eating. And so if they're binging at 3:00 in the afternoon, they literally pass out, they wake up at 1 a.m, and now they're awake and they can't get back to sleep. I've worked with other people who binge eat and then they can't get to sleep because their body is almost like, I can't lay down now. I need to move to digest this food. So absolutely, the two together really can, that's why having both can exacerbate the presentation of both of them. And studies show that people with ADHD and eating disorders will see the eating disorder symptoms typically is more severe and the ADHD symptoms is more severe.
Mm-hmm. Well, I think the hour is up. Thanks so much for being here. It really was excellent and enlightening. That's all I can really say. It was fantastic.
Absolutely. And if people, if I didn't get to certain questions, people can feel free to, shoot me an email and I'd be happy to answer any questions that I get through email.
Okay, that's great. And thanks to all of the attendees for joining us. You came up with some unbelievably good questions, insightful stuff as well. So thank you. And make sure you don't miss future Attitude webinars, ADHD expert articles, or important research updates by signing up to receive our free email newsletters at attitudemag.com/newsletters. Thanks everyone for being here and have a great day.
For more Attitude podcasts and information on living well with attention deficit, visit attitudemag.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com. That's ADDITUDEMAG.com.